Good morning po, ma'am. Ma'am,
Morning po.
Hello, yan, sorry na kanina. Hi, good morning. I'm Dr. Crystal Katiburok from the section of Hematology. So, this is section D&E.
Yes po.
yes po, Doc.
So, section D&E, is correct? Okay, hello? So, ano ba ang tawag dito? Okay, can you hear me?
Yes po, Doc.
Yes po, Doc.
Okay, so let's start. So our topic for today is about bleeding and clotting disorders. Our objectives are to discuss the physiology of coagulation, anticoagulation and fibrinolysis, and also discuss the disease entities that involve primary and secondary coagulation and other coagulation disorders. So when you say coagulation, it means clotting. This is the process by which blood changes from a liquid to a gel form and eventually forming a blood clot. And this formation of blood clot will result in hemostasis, the cessation of blood loss from a damaged vessel. So that's for coagulation. So this illustration shows us briefly what happens when you have an injured blood vessel. As you will see on the left upper portion, you have first vasoconstriction, followed by primary hemostasis, then secondary hemostasis, and then eventually thrombus and antithrombotic events, and later on we will see there would also be fibrinolysis. So the first response of an injured blood vessel will be reflex vasoconstriction. So again, what will be the first response of an injured blood vessel? Again, it would be reflex vasoconstriction. So this reflex vasoconstriction is brought about by local sympathetic nerve action as well as endothelin release from the endothelium. So just to take note that this is the anatomy of the blood vessel. First, you have the endothelium, followed by the basement membrane, which is very rich, which has very rich proteins like collagen, your von Willebrand factor, and followed by the arteriolar smooth muscle. So this reflex vasoconstriction that is brought about by local sympathetic reactions coming from the arteriolar smooth muscle contraction followed by release of endothelin from the endothelium will eventually result to this reflex vasoconstriction. This will result to controlling the bleeding only on smaller blood vessels, okay? Only on the smaller blood vessels. Hence, it will be followed immediately by what we call the primary hemostasis, okay? So in summary, this primary hemostasis will first demonstrate platelet adhesion, followed by the different platelet activation, shape change, granule release, and platelet recruitment, and then eventually platelet aggregation and forming the hemostatic plug. So let's go to the primary hemostasis. So primary hemostasis primarily involves platelets, okay? These are not secondary coagulation factors. It involves the platelets. Remember, in your blood, you have the cellular and the liquid component, okay, or the fluid component. So in the cellular component, you have red blood cells, white blood cells, and the platelets. So if you will take a look at the picture at the left side, this is an injured blood vessel. These cells are the endothelium cell. As you will see, there is one endothelium cell that is missing in the middle. These spherical forms are represented by your platelets, followed by this proteins called your fibrinogen. Okay? Underneath, or the subendothelium, you will see this VWF, which stands for your von Willebrand factor. And aside from your von Willebrand factor, you will also see collagen. Okay, one important protein that you will see in the subendothelium, the collagen and your von Willebrand factor. And of course, your extracellular matrix. So what happens when there is blood vessel injury? So when there's injury, there is exposure of the subendothelium because there is damage at the endothelial lining. So when there's damage, the subendothelium is exposed, exposing important proteins such as your von Willebrand factor and collagen. So upon this exposure, your platelets adhere to these proteins. So as you will see, these platelets, particularly in the platelets, you have a glycoprotein receptor. These receptors are seen on the membrane of the platelets. Your glycoprotein 1b will bind with von Willebrand factor, and your glycoprotein alpha 2, alpha 2 and beta 1. Alpha 2 beta 1 glycoprotein receptor. This receptor is seen in the membrane of your platelets, along with your glycoprotein 6. Both of these receptors bind collagen. So this platelets will adhere to the subendothelium. So that's one of the first steps. Okay. Now, when you have platelet adhesion, what will happen is that inside the platelet, there will have an activated intracellular signaling. Okay. After that activated intracellular signaling, what happens next is your platelet activation. So from the platelet adhesion will activation will occur, and then you will see that there will be three processes that occur during platelet activation. Number one, what happens? Platelets change their shape. So from a spherical form, the platelets become stellate, as you will see in this picture. After the change in shape, you will have what you call the granule release. Okay. When platelets undergo shape change, they also have what we call the phospholipid metabolism. And this metabolism would promote the release of dense granules. These granules are your adenosine diphosphate and your thromboxane A2. These two granules, when released, will promote number 3, platelet recruitment. So the presence of ADP and thromboxane A2 will recruit more inactivated platelets at the site of the injury. So as you will see here again, what are the three processes that occur during platelet activation? You have one, platelet change shape. Second would be granule release. And then third would be platelet recruitment. The last process will be what we call platelet aggregation. In platelet aggregation, what happens is that the glycoprotein 2B, 3A receptor that is seen in the membrane of the platelets are activated. And once they are activated, they now bind fibrinogen. Okay? So when they bind fibrinogen, this fibrinogen will bridge adjacent platelets, and eventually they will form what you call the primary platelet plug. Okay? So again, this is what happens during when there is a blood vessel injury, and this is how primary hemostasis work. From platelet adhesion followed by your platelet activation, and in platelet activation, you have your platelet shape change, granule release, platelet recruitment, and eventually platelet aggregation. And importantly, in this platelet aggregation, you will form the primary platelet plug. However, in primary platelet plug, it can only control bleeding at the small vessels. Usually, it's not enough to control bleeding in the larger vessels. Hence, you have After the primary hemostasis, you have the secondary hemostasis. Okay? So let's go to the secondary hemostasis. In secondary hemostasis, it is now, what is involved now are your activated coagulation factors. Remember, in primary hemostasis, going back, it is the platelets that are primarily involved. In secondary hemostasis, you will see that it's the activated coagulation factors, specifically thrombin, that forms an insoluble cross-linked fibrin in order to reinforce the platelet plug. Remember that as I've mentioned a while ago, the primary platelet plug is not enough to control bleeding in the larger blood vessels. So, what are these activated coagulation factors? These are your activated coagulation factors. Okay? So these coagulation factors are synthesized in the liver, and as you will take note, they are all identified in Roman numerals. Okay? They are identified in the way that they were discovered. Whichever was discovered first is numbered as, are identified as such. Okay, so we always use Roman numeral numbers when identifying coagulation factors. And then you also place an A at the side. For example, if you have 1A, it means it is already an activated form. Okay, so if you only see a coagulation factor without the A beside it, it means it is still a zymogen. It is inactivated. Okay. So what are your coagulation factors? First one, you have plus factor number 1, fibrinogen, followed by prothrombin, your tissue factor, which is factor 3, factor 4 for calcium, factor 5, proaccellerin, factor 6, factor 7, this, we call it the stable factor of proconvertin, and very importantly, you have factor 8, which is the anti-hemophilic factor 8, factor A. Remember, you have two types of hemophilia. It is a type of deficiency where you see it, it's an X-linked type of genetic problem where there is a deficiency in your factor 8, so you call that hemophilia A. When you have deficiency of the factor 9, you call it hemophilia B. And remember, factor 9 is what you call the anti-hemophilic factor B or Christmas factor. You also have factor 10, the Stewart-Prower factor, factor 11, factor 10, 12, and factor 13. Okay. Now, as you will see later on, you also have your prekallikrein and your high molecular weight kininogen. These are very important enzymes that will involve the intrinsic pathway of coagulation. So in three distinct pathways. You have the extrinsic, the intrinsic, and the common pathway. So this is the picture which shows the secondary hemostasis. Okay? So tapos na tayo sa primary hemostasis. What happens is that you need to enforce the platelet plug. So the secondary hemostasis occurs. Let's go first to the extrinsic pathway. We also have the intrinsic pathway. And when you see factor 10 activated, that is the start of the common pathway. Now for the extrinsic pathway, as exemplified by the light blue colored font, first is when there is tissue injury or any vascular injury will release TF or tissue factor. So this tissue factor will activate your factor 7 to become your activated factor 7. This activated factor 7 along with tissue factor forms a complex. And this complex is what we call the extrinsic tenase complex, okay? So this extrinsic tenase complex is very important because it will activate factor 10 to activated factor 10A, okay? So the extrinsic pathway is a bit short in comparison to the intrinsic pathway. The extrinsic pathway also, as you will see, it can have an alternative pathway. It can also activate your factor 9. Okay? However, in vitro, this extrinsic tenase prefers the substrate factor 10 over factor 9. Okay? So that's for your extrinsic pathway. Now, what about the intrinsic pathway? So the intrinsic pathway starts with tissue injury. Later on, we will see another picture showing the activation of factor 11. So we go first here, the activated factor 11 can activate factor 9, and the combination or the complex of what we, when you have a complex of your factor 9A, activated factor 8, your PS or phosphatidylserine or calcium, you all call this the intrinsic tenase. Okay? So tenase meaning 10, it will cleave the factor 10. Kaya we call it tenase. Okay? So this is the intrinsic tenase that will be able to activate your factor 10 to activated factor 10A. Okay? Now, what's the difference again from the extrinsic pathway? Aside from all these factors, the intrinsic pathway occurs, this occurs on platelets, okay? It occurs on platelets where your extrinsic tenase, its site of activation occurs in fibroblast. Okay. Now, since we've discussed extrinsic and the intrinsic pathway, again, you have to know all the factors that are involved in each pathway. Now we go now to the common pathway. So the common pathway will involve your factor 10A, activated factor 10A, your activated factor 5 with the combination of phosphatidylserine and calcium. Remember, this phosphatidylserine is an anionic location which is actually promoted by your platelets. Okay, so you will see that your platelets are helps in the formation of your secondary coagulation as well. But again, the primary factors that are involved here would be your coagulation factor. So from your factor 10A, your activated factor 5A, all of this will activate your prothrombin to become thrombin. Okay? Remember, prothrombin is factor 2. Thrombin can activate two factors. Number one, it can cleave factor 1, or serum fibrinogen, to become a soluble fibrin. However, this soluble fibrin only forms a soft clot. Okay, you can still bleed if you have um, only a soluble fibrin. So it needs the help of an activated factor 13 in order to cross-link this soluble fibrin to an insoluble type cross-linked fibrin, which is brought about by your activated factor 13. Okay, so that's very important. And so coming from factor 10A to factor 5A to prothrombin becoming thrombin, and then activating fibrinogen to soluble fibrin, and activating factor 13 to activated factor 13, this encompasses your common pathway. Okay, so that is the secondary hemostasis from the extrinsic pathway to the intrinsic pathway down to the common pathway. This is a very busy slide, but we can go through it because we've already discussed in the previous slides what are the different the pathways of the extrinsic, the intrinsic, and the common pathway. So first, if you have a wound injury or a blood surface injury, it will release your factor 3 or your tissue factor. So this tissue factor will activate your factor 7 to become your activated factor 7A. So remember, you have a complex, your activated factor 7, with tissue factor, it is your extrinsic kinase. And later on, it will activate factor 10 to become the activated factor 10, which is the first part of the common pathway. For the intrinsic pathway, again, this portion this is the portion that was not illustrated in the previous slides. During blood trauma or if there is contact with collagen, the prekallikrein is converted to kallikrein. And as you will see, this kallikrein is also a protein that can activate factor 12. Okay? So this activated factor 12A can activate factor 11 to activated factor A. Okay? You're also high molecular weight kininogen are very important proteins that can also activate your factor 12A. And when you have an activated factor 11, it can activate factor 9. So when you have the intrinsic kinase that will be composed of your activated factor 9, your phospholipid or phosphatidylserine, your calcium, and your factor 8A, all of this is what you call the intrinsic kinase, and it will activate now your factor 10. Now your activated factor 10A with the combination of your activated 5A will convert prothrombin to become the activated form or thrombin. Now, thrombin is a very important coagulation factor. Later on, as you will see, there will be some anticoagulant mechanism that will try to balance off this coagulation process, okay? And this thrombin, remember, it can activate, number one, it can lyse or your fibrinogen or cleave fibrinogen to form fibrin, but it is only a soft clot. So it needs to activate factor 13 or what we call the fibrin stabilizing factor to release an activated form of factor 13 and eventually forming a hard clot or a cross-linked insoluble fibrin clot. Okay, so that's the end of the secondary hemostasis. So when you have these stages of hemostasis, how long does it occur? Usually in the primary hemostasis that involve the platelets, usually within 5 minutes, the site of injury is already sealed. Secondary hemostasis, from the time the coagulation is formed until the fibrin mesh reinforces the frail platelet plug, it sometimes needs at least hours in order to control, for the secondary coagulation to occur. Of course, remember, we are initially talking about coagulation. In the blood, there should always be a balance between this coagulation and anticoagulation. Because if you have too much of this primary and secondary hemostasis or your primary and secondary coagulation, you will keep on clotting all over. And of course, if there's too much clot, this would impair oxygenation to your tissues and you can have tissue damage. Hence, the body is created in a way that you should have a balance between your procoagulants and your anticoagulants. So later on, as you will see, when there is tissue injury, once the injury has been repaired, there would be what we call fibrinolysis. That clot should be eventually be dissolved, okay, once it is already repaired. So this is the coagulation cascade again. But remember that the extrinsic factor can be measured using what you call the PT or your prothrombin time. And the secondary coagulation can be measured by using the APTT or your activated partial thromboplastin time. So let's go first to the PT. So PT measures the extrinsic and the common pathway factors. except for the tissue factor because it is the factor that we add as the clot activator along with calcium. So usually you get a sample of the patient's serum and you check how long will this serum clot when we give this coagulation factors. So normally, prothrombin time or the extrinsic factor usually is around 12 to 13 seconds. So anything beyond that, it would depend again on the laboratory control. Sometimes the range is different from different laboratories. So you should always check the range if it's in between the allotted range. If it's more than 1.5 times the upper portion of the limit of the range, then it is already prolonged. Okay, so imagine if you cut nagkasugat ka, tapos you have dapat in a span of how many seconds it should stop already. Okay, so what about PTT or your activated partial thromboplastin time? Again, this test measures the function of the intrinsic and the common pathways. Okay, so again, you can add a surface activator here or phospholipid and calcium to the plasma of your patient. And you will see how long does the clot form in this specimen. Usually for the APTT or the intrinsic pathway, the normal levels would be at around 23 to 36.4 seconds. And again, it may usually it's in this range, but sometimes other laboratories will say around 32 to 37. Others will say it's 29 to 35. So it depends on the range that is given by the laboratory. So going back, as I've mentioned a while ago, we have been talking about primary hemostasis and secondary hemostasis. As you will see, these are all clot formers or the clot formation. You always need to know that there should be a balance between the clot formation and clot dissolution. So in order for the clot to stop having clots, you need to have an anticoagulant. So later on, we will discuss that in the body, there are what we call the naturally occurring anticoagulant proteins. Aside from that, when the tissue, as I've mentioned, has already been repaired and the coagulation factors has been controlled or it already decreased already, there's the decrease in thrombin generation, then fibrinolysis will occur. Again, there should be a balance between the clotting and the bleeding. Remember that in order for us to have a proper hemostasis, you should check the vasculature, coagulation proteins, and the platelets. And remember, Verkov's triad. If there is what you call the hypercoagulable state, when the patient is a clot former or the patient has a clot formation, what are the three factors that are usually involved? Number one would be if there is blood flow abnormality or if there is alteration in the hemodynamic forces, there would be stasis. Second, others would have what we call the hypercoagulable state, those who are bedridden, or some would have clot formers. And of course, if you have endothelial cell dysfunction, endothelial cell injury as such when it happens with myocardial infarction, all of these factors will lead that's what we call Verkov's triad. It will all lead to clot formation. So we have discussed vasoconstriction, primary hemostasis, and secondary hemostasis. Again, remember primary hemostasis, the platelets are primarily involved. Secondary hemostasis, it would be the coagulation factors. So second, and the last portion would be, you should need the anticoagulants or the antithrombotic events. And later on, and after the antithrombotic events, we will talk about fibrinolysis. So there are three naturally occurring anticoagulants in the body. You have the tissue factor pathway inhibitor or your TFPI. You have the antithrombin 3 and the protein C and S. So let's go first to the tissue factor pathway inhibitor or your TFPI. So if you will see, this blue portion is actually the extrinsic pathway. You will see this is a tissue factor and your factor 7. And the primary inhibitor of the extrinsic pathway is the tissue factor pathway inhibitor, as you will see. So it's able to inhibit your extrinsic kinase, so your TF and your factor 7A complex, and it can likewise inhibit not only your tissue factor and factor 7A, but also the activated factor 10A. Okay? So, your TFPI, it's actually also promoted by protein S. Later on, you will see that they are both cofactors of protein C. Usually, this tissue factor pathway inhibitor may also weakly inhibit your factor 7. But anyway, usually they ask kasi in the exams what will be the main inhibitor of the extrinsic pathway. Then don't forget this. It's the TFPI or the tissue factor pathway inhibitor. So that's the first anticoagulant. For the second anticoagulant, you have the antithrombin. So antithrombin, as you will see, it is depicted here, your AT3. It can inhibit most of the coagulation factors in the intrinsic pathway, from factor 12, factor 2, factor 9, factor 10, factor 11, and factor 12A. Halos lahat kaya niyang i-inhibit. But its greatest inhibitory effect is on factor 2A or your thrombin. Okay, that's why I mentioned during when I was discussing the thrombin factor. Antithrombin 3 has its greatest inhibitory effect on thrombin or your factor 2A. And remember, heparin. No? Heparin enhances the activity of your antithrombin. So heparin is actually used for many clinical purposes. For example, if you know any of your friends or relatives who are undergoing hemodialysis, we give heparin or low molecular weight heparin so that whenever they have their dialysis for 4 or sometimes 6 hours, when the blood is taken away from them, coming from the IJ or coming from the AV fistula, it should not clot. So in order for that not to clot, aside from the, of course, the tubing having an heparinized tubes already, you can also give additional injections of this heparin or sometimes low molecular weight proteins in order to stop coagulation. Kasi nga ayaw mo mag-clot yung blood during the dialysis. Okay? Dapat it should not clot, okay, during dialysis. Now, when you have a patient with myocardial infarction or heart attack siya, lalo na if you have the NSTEMI or STEMI, you give, actually especially for NSTEMI, you give this low molecular weight heparin. Remember, the basis for giving this is that there was a clot that lodged, whether because of a cholesterol plaque that was formed in the coronary arteries and then produced a clot in one of the very important coronary arteries, producing now myocardial ischemia, presenting as chest pain to these patients. Then you give low molecular weight heparin. So that's its clinical use, okay? Kasi ayaw mo siyang mag-clot. Nag-clot na nga siya kasi inatake na siya sa puso. May clot na dun sa coronary artery. So you give this low molecular weight heparin in order for clot not to be formed again. So that's for the second. You have your antithrombin 3. Now, what about the third one? You have the protein C. So protein C is actually a thrombin inhibitor also. but it is a vitamin K dependent enzyme, and it's mostly produced in the liver. What's important in this in protein C, remember there's also protein S, is that this is activated when thrombin binds to thrombomodulin. No? So meron pa siyang, it has an additional protein. It gets activated when thrombin binds to thrombomodulin. And this thrombomodulin can inhibit your factor 5A and your factor 8A. When you inhibit both of these factors, remember your factor 8A is an important complex in your intrinsic kinase pathway. And your factor 5A is needed to, as a complex with your activated factor 10A in order to activate your prothrombin to thrombin. So if you have this anticoagulant or your protein C, then definitely there would be a decrease in your thrombin generation. Hence, it is also a very important anticoagulant in the body. So again, what are your three anticoagulants? You have your TFPI or your tissue factor pathway inhibitor. Second is that you have the antithrombin 3. And third, you have the protein C, protein S. Okay? So we have discussed the antithrombotic events. As I've mentioned, when you have a vascular injury, once the tissue has been repaired, then fibrinolysis will occur. Normally, when you have actually tissue injury, fibrinolysis is also started. However, because of the thrombin that is available in large amounts in the blood, it will prevent the release or of this TPA or your tissue plasminogen activators of fibrinolysis. So once the thrombin has been already decreased, then fibrinolysis will occur already. So again, fibrinolysis, this is the dissolution of the fibrin clot. Remember, this will occur only once the tissue has been repaired. And sometimes it occurs after 5 days, okay, or days. And how do you dissolve the fibrin clot? It's usually by the protease plasmin, okay? And it comes from the endothelial cells as well. So this is a picture. Remember, there are two fibrinolytic pathways, by the way. We call it the TPA, the tissue plasminogen activator. And can you hear me? Sorry. Parang nagano yung aking.
Yes po.
Okay. Wait. Okay. So we have two types of fibrinolytic pathways. You have the tissue plasminogen activator or the TPA. You also have the urokinase plasminogen activator or the UPA. All of this can be seen it can be released by the endothelial cells. So when these are released, normally you have plasminogen in the blood, but this is the inactivated form. So with the presence of your TPA and UPA, it will convert your plasminogen to plasmin. And remember, plasmin, it is a protease, okay? It will lyse the fibrin clot. So after that, the clot will lyse and releasing degradation products. And again, these are all the balance that occurs in our body, from the primary and the secondary coagulation down to our anticoagulant mechanism. And when fully healed, then you will have the fibrinolytic pathways. Okay, so this is actually we've discussed all of this, from of course the reflex vasoconstriction to the primary hemostasis, which is primarily involved your platelets, then secondary hemostasis, the antithrombotic events or antithrombic thrombotic proteins. You have your TFPI, antithrombin 3, and your protein C and protein S. And then, finally, fibrinolysis in the form of your tissue plasminogen activators and UPA. Okay? So, you will see how beautiful blood is because there should be a balance between the clotting and the bleeding. Okay, and eventually, if there's a clot, it should be eventually be lysed or fibrinolysed. Now, what happens if you have problems in this normal physiological process? So this picture just tells us, so at the left side, these are the diseases that involve problems in your platelets, whether in quantity or quality. And the right portion would be problems with secondary hemostasis. So let's go first to, in general, how can you distinguish primary versus secondary hemostasis? So you will see defects in primary hemostasis, as we've mentioned. If you have platelet problems, the onset are usually immediate, and usually the sites are mucosal. No? Mucosal saan? They bleed in the nose as epistaxis. They will come to you with gum bleeding. Usually mucocutaneous ang presentation ng bleeding of a patient with a primary hemostatic defect. And as you will see, aside from epistaxis and gum bleeding, they will present as PTK, small pinpoint hemorrhagic bleed on the skin, or ecchymosis. They are not really very big hematomas. Okay? So for the sex, they have very large hematomas. Okay? So for the sex, they have rare that they have a positive family history, but von Willebrand disease is one type of a platelet quality dysfunction where there is a problem with the platelet receptor and the collagen or protein interaction. It is the quality ang problem, not really the quantity of the platelets. And this can be inherited, the von Willebrand disease. Now, the response to therapy is usually if you have a platelet defect, most of the time, it can be controlled by local measures. So for example, even if you just do compress at the site of the injury, it can be controlled. However, it's different when you have defects in secondary hemostasis. Usually, the onset may be delayed, but you will see the sites of injury. They are usually on the deep joints or in the deep muscles. And when you see them, they have very large or solitary ecchymosis. They may have large hematomas or hemarthrosis. There's bleeding in the knee. So usually you see this types of secondary hemostasis. So when you say secondary hemostasis, there's a problem in the coagulation factor. So it may be inherited in 80 to 90%, usually in males. So usually you see that in factor 8 deficiency like hemophilia A, or factor 9 deficiency such as hemophilia B. So of course the family history is common, but the response to therapy, it's a bit difficult because you have to give um, specific coagulation therapy for this patient. For example, factor 8. When you have hemophilia A, you have to give factor 8 infusion. Or for hemophilia B, you need to give factor 9 infusion. If there is a paucity, or if you do not have, it's not readily available, you can give cryoprecipitate or plasma or fresh frozen plasma for these patients. And again, when they present, talagang mas toxic tingnan ng mga secondary defects in secondary hemostasis. So these are some of the pictures, as you will see. For those with primary hemostatic defect, they may have some hemorrhagic pinpoint bleeding from the eyes. Mucocutaneous kasi sila. Sometimes they have epistaxis, gum bleeding, and may have TTK. Okay. Now, in those with secondary hemostasis, as you will see, they have very large hematomas, and here they have what we call hemarthrosis. Okay, this is very common among patients with hemophilia. So again, going back, we will be discussing primary hemostasis. In passing, von Willebrand's disease, your Glanzmann thrombocythemia, Bernard-Soulier, immune thrombocytopenic purpura, and in between you have the TTP, DIC. It means it may, especially DIC, it may present with thrombocytopenia, and your PT and PTT may also be deranged. Okay, that's why they are in the middle. Okay, so then this is the secondary hemostasis. So let's go first to primary hemostasis. So what are the disorders of platelet function? So sometimes the platelets itself are okay, the quantity is adequate. However, the receptors that is seen on the platelet membrane is inadequate. So if you have what you call the glycoprotein 1B deficiency, so this is a membrane receptor on the surface of your platelet, and there's deficiency of the 1B, you call it the Bernard-Soulier syndrome. So usually these are children, who will come to you because of mucocutaneous bleeding, and um, when you see the CBC, the platelets are normal in number. However, it is the function that is abnormal. Now, in glycoprotein 2B3A deficiency, you can see this in patients with Glanzmann thrombocythemia. Okay, so if you have this 2B3A deficiency, it is a type of membrane receptor. Remember your 2B3A, going back to your to the primary hemostasis, your 2B3A receptor are the ones that are responsible for binding fibrinogen. Okay, so that's really very important. They will really bleed. Okay. Then aside from that, sometimes you may have disorders of platelet secretion, such as abnormalities of platelet granules or storage pool diseases. Remember, in during platelet activation, you have your shape change, platelet recruitment. So if there is platelets, then you may present as mucocutaneous bleeding. Sometimes it's not the quality of the platelet that is involved, but the quantity. So the normal platelet count is around 150,000 to 450,000. Sometimes you may be presented with a bleeding patient and thrombocytopenic as well. So what are the disorders that you can think of if you are presented as such? So you may have the myeloproliferative disorders, and also myeloproliferative. We have a lot of myeloproliferative disorders. You have polycythemia vera, ET, chronic myelogenous leukemias, and your primary myelofibrosis. So any problem in the bone marrow, especially if they are already accelerating, all of this can convert to leukemia. They may present with thrombocytopenia. Second, and which is most commonly that most clinicians will see, would be the ITP, or immune thrombocytopenic purpura. Now, your ITP may be idiopathic or primary, meaning it doesn't have any cause, or it can be secondary coming from an infection, secondary coming from an immune disorder such as systemic lupus erythematosus, secondary ITP coming from a malignancy or a bone marrow problem. So again, we will be discussing in detail your ITP. There are also other secondary systemic disorders that can present as thrombocytopenia. And one can be uremia, for those who are needing dialysis already. Those with severe liver disease, remember thrombopoietin is the major stimulant of megakaryocytic production. So thrombopoietin is primarily seen in the liver. Of course, patients who underwent cardiopulmonary bypass may have functional defects or thrombocytopenia on the CBC. Often you will also see in the clinical practice drug-induced types of thrombocytopenia. So all you need to do is just remove the drug, and then the platelets should increase by itself. So let's go to, in general, before going to ITP, what are the causes of thrombocytopenia? It may involve a decrease in production. So you may see this among patients with myelodysplastic syndrome. If the megakaryocyte or the mother platelet, you call that the mother platelet, it is the megakaryocyte production, it's already dysplastic, may sira na yung pinaka-factory ng platelet in the bone marrow. So you anticipate a decreased production. Your immune thrombocytopenia, in the recent years, they have also implicated that there is also a decrease in bone marrow function or release of platelets from the bone marrow. Increased destruction may be seen in immune and non-immune. So this increased destruction means that the bone marrow is normal, but when the platelets are distributed peripherally, they become destroyed, hence the thrombocytopenia. So it can be destroyed either immune types like your systemic lupus erythematosus or diffuse toxic goiter, or sometimes the non-immune destruction such as infection or, or even drug-induced types, okay? What about splenic sequestration? So splenic sequestration, usually the spleen eats the platelets. So you can see this usually in hypersplenism among patients with liver cirrhosis. They may present as pancytopenia. Okay, so that's one example. And of course, sometimes you only have delusional thrombocytopenia. So because of too much fluids that are given to the patient, hence the thrombocytopenia. So this picture at the right upper side shows this is an oil immersion field of a peripheral blood smear of a patient with thrombocytopenia. Usually, you should see at least 8 to 11 platelets per oil immersion field. And at this picture, you only see one. Okay, so immune thrombocytopenia may be of two types. You have the idiopathic or the primary, and you may have secondary types, your secondary ITP. So secondary ITP may come from infection. So if you have secondary ITP coming from an infection, you just need to treat the infection. Then you treat the infection, then the platelet will recover by itself. Collagen vascular diseases or other immunologic types of diseases such as systemic lupus erythematosus may also present with thrombocytopenia. So all you need to do again is treat the underlying cause. Okay. What about lymphoproliferative disorders? Lymphoproliferative disorders are usually diseases that involves the lymph nodes, or whether they can also involve the bone marrow. For example, lymphoma or some leukemias such as chronic lymphocytic leukemias. So these lymphoproliferative disorders can also have thrombocytopenia. And again, all you need to do is treat the underlying cause. Solid tumors can also be a factor. Sometimes, especially for those who have metastasized, then you anticipate a secondary thrombocytopenia in the bone marrow, metastasized to the bone marrow, and of course, drug-induced. Okay. So what are the features of ITP? So primarily, what we're thinking of here of what ITP is the idiopathic type, okay? The acute ITP is generally in children. They are of the acute type, okay? There's no such predilection, but usually there is an antecedent infection that is commonly seen among patients or among children with acute ITP. And the onset of bleeding is usually abrupt. And when you see the oral cavity, they have a lot of hemorrhagic bulla. You see this among children. It's common, but in adults, it is not. The platelet count may be low as 20,000, but still it's very variable. And usually you have eosinophilia. The duration is around 2 to 6 weeks, but what's very good in acute ITP among children is that when you give steroids, they have spontaneous remission in almost 80% of cases. What about chronic ITP? So chronic ITP is usually seen among the older age group or the adult age group, and it is the female that has sexual predilection. Although an antecedent infection is usually unusual and the bleeding is insidious. Ano? Hindi siya talaga mableed eh. But when you see them, their platelet counts may be very variable, ano? Not always 30 to 80,000. Sometimes I have patients even below 30,000. But what's difficult with ITP among the adult age group is that the remission rate is uncommon. Ang hirap nilang makontrol. Ano? So you will see patients with these types of diseases, especially the adult ones. Ano, parati silang nagre-relapse, ano? They have persistently low platelets and they would have you would have difficulty sometimes in inducing spontaneous remission among these patients. So this is the pathogenesis of chronic ITP. Primarily, the pathophysiology is there is an antiplatelet antibody that sensitizes the platelet. And this sensitized platelet is eventually eaten up by the splenic macrophage. Okay? Hence, when they are taken up by the splenic macrophage, it will result to its decrease in number, hence the thrombocytopenia. So these are some of the laboratory findings. So normally, you have at least, these are the red blood cells. And this is a peripheral picture of the peripheral blood smear of a normal patient with, as a patient with normal CBC. So you have the red blood cells. This is a neutrophil. And this small spherical sphere, or this small areas are what you call the platelets, okay? Now, in the lower portion, you will see that you only have one platelet here, since hence the thrombocytopenia. Now, this picture here shows a megakaryocyte in the bone marrow. So remember, this is the precursor of your platelets, the megakaryocyte. When you do bone marrow aspiration and biopsy among these patients with immune thrombocytopenia, you expect actually plenty or even normal megakaryocytes, okay? Remember megakaryocytes are, when megakaryocytes release platelets in the system, the pathophysiologic problem in chronic ITP is that there are autoantibodies against this platelet. So it's primarily a peripheral destruction. Okay, kaya when you do the BMA, most of them they have what you call megakaryocytic hyperplasia. Madami naman yung mother megakaryocytes. Pero pag lumalabas na sa system or the peripheral blood, these platelets get sensitized, okay? Because there is what you call this one. They have anti-platelet antibodies. And when they become sensitized, they are eaten up by the splenic macrophage. So how do you treat your chronic ITP? This is a very good picture that shows how you can address the different pathophysiologic mechanisms and then addressing each with different medications. So remember, number one, this is a stellate type of platelet. As you will see, you have your autoantibodies that are desensitized. And these autoantibodies are actually coming from your B lymphocytes, okay? And remember, B lymphocytes can actually be stimulated by your T cells, okay? So your T cells can activate the B cell or your B lymphocytes, and these B lymphocytes are the one that are producing these anti-platelet antibodies. So these anti-platelet antibodies can sensitize your platelets, and eventually when they pass through the spleen, they are eaten up by your splenic macrophage, okay? Now, it has also been postulated that in the bone marrow, sometimes you will see that there's also a decrease in megakaryocytic release of these platelets. Hence, One area uh, to consider is that in ITP, you can give what you call your thrombopoietin receptor agonist, or L-thrombopag. Maybe you've heard some of the patients or some of your relatives taking L-thrombopag. It's actually an agonist, so it stimulates the bone marrow to release more platelets into the peripheral system. Now, aside from the thrombopoietin, you can actually give steroids in order to address this. But before going to that, look at the T cell. The T cell has also been a target in treating your chronic ITP. They say that T cell, through the CD40 and CD154 ligand, they can stimulate these B cells to promote more antibodies. So controlling this T cell, whether you can give azathioprine, cyclophosphamide, cyclosporin, corticosteroids, or danazole. Okay, so that's one. That can be one area, where you can control, this chronic ITP. What about your B lymphocytes? Since your B lymphocytes has been the one implicated in releasing all of these autoantibodies, then you can give what, IVIG, you give anti-CD20. CD20, remember CD20 is a receptor of the B lymphocytes. So you can give actually rituximab to these patients. And some would even advocate the removal of these antibodies by using plasmapheresis. So plasmapheresis is actually a technique or where the patient's plasma is removed from the system and then cleaned through a special machine. Eventually, when it is returned back to the body, most of these antibodies has been removed. Now, another way to remove this antibody is that you can give steroids to dampen the antibodies, IVIG, you can give anti-D immunoglobulin, danazole, or even vinca alkaloids. And of course, lastly, remember, it is the spleen that eats all of these sensitized platelets. Hence, for those with refractory chronic ITP, one choice is to do splenectomy. You remove the spleen. But of course, before doing splenectomy, you have to prime the patient first. You have to vaccinate the patient against three very important microorganisms: the Neisseria meningitidis, your influenza, and your Streptococcus pneumoniae. Okay, Haemophilus influenza. So your splenectomy. So actually, that's for the last slide for ITP. Now we go to problems that may occur in the primary and secondary hemostasis. So we go first to, we go first to secondary hemostasis first. So hemophilia. Uh, I mentioned a while ago that if you have factor 8 deficiency, that would be hemophilia A. And if you have factor 9 deficiency, that would be hemophilia B. Remember, these are sex-linked. And it would depend whether you have a mild, moderate, or severe type of hemophilia. It depends on the levels of your factor 8. And usually, they do not have, they have a normal platelet, but because the factor 8 is deficient, so you expect the PTT to be prolonged. But the PT, which is reflective of the extrinsic pathway, the PT should be normal. And the PTT, which is the intrinsic pathway, remember the intrinsic pathway, you will see factor 8 there, that would be the anticipated prolongation. Your PTT should be prolonged. Anyway, the treatment for hemophilia, especially for those with bleeding, is aside from giving your factor 8, giving factor 8 or factor 9, whether for respectively for hemophilia A and B. You can also give fresh frozen plasma or cryoprecipitate to this patient. What can cure actually here is, of course, liver transplantation. Remember, coagulation factors are all formed in the liver. Okay. So that's for the secondary hemostasis. What about those that disease entities or conditions where the platelets and your primary and secondary coagulation parameters can be affected? So we go now to disseminated intravascular coagulation, or DIC. So DIC is actually not a disease, but it is a condition, okay? Hindi siya disease. It comes from either because the patient has sepsis or an infection, whether the patient had trauma, whether tissue injury, head injury, or fat embolism from pregnancy, cancer, or any obstetrical complications, vascular disorders, especially systemic lupus erythematosus, reactions to toxins, or even hemolytic or blood transfusion reactions. So what happens in DIC? So in DIC, or disseminated intravascular coagulation, as the name implies, there is too much coagulation that occurs. So what happens? There is intravascular deposition of the fibrin, and there is thrombosis at the small and mid-sized vessels, and there is eventually organ failure. The problem here is that there are some mechanisms, the normal mechanism, your anticoagulants cannot interfere with this mechanism. Sobrang daming deposit ng clots everywhere. Until such a time when, because of this massive or disseminated coagulation has occurred, all of your coagulation factors and including the platelets are all consumed. Naubos na. It is consumed in the process of all of the coagulation all over the body. And then, after the coagulation, the patient will already bleed. The patient will keep on bleeding everywhere, no? Sa ilong, minsan at the IV sites, ano? Sometimes, I have patients who are in the IC, had continuous hematuria, or my last was the tracheostomy. Bleed ng bleed, okay? So again, DIC is not a disease. It is a secondary condition brought about by another underlying problem. So for example, this is actually a patient with APAS, antiphospholipid antibody disease, or syndrome. So may APAS to. Aside from that, you can also have infection or purpura fulminans. If there's too much of the activation of the coagulation factors because brought about by another systemic problem, then you can have DIC. So this one, you will see there are some thrombosis already in the toes of the patient. There is such a thing as acute versus chronic DIC, and definitely the acute DIC, when exposed, when the when the procoagulants are exposed, that who keeps on bleeding, they will bleed everywhere, whether from the nose or from the mouth, from the trach, or the IV site, there would be oozing. And the problem here is that, the compensatory hemostatic mechanisms are overwhelmed. Wala ng hemostasis. It is a widespread coagulation, and eventually when all the proteins are consumed, there would be bleeding. What about chronic DIC? In chronic DIC, usually in chronic DIC, these are the ones that you see in among cancer patients. Yung mga acute DIC, you see this among patients who have suffered trauma, yung mga vehicular accident na patients, those who have severe sepsis, okay, or those who had obstetric complications. Now, in chronic DIC, usually you see this among cancer patients. They have a compensated state. Actually, you will not see them, if they bleed, it's just intermittent, not really that profuse bleeding as such as compared to acute DIC. Because the rationale here is that even if they have DIC, their compensatory mechanisms are not overwhelmed. But of course, again, the treatment between acute and chronic DIC is just the same. Again, going back to the pathogenesis, remember, because of the underlying problem, whether from an infection or trauma, there will be release of these cytokines. And of course, the release of these cytokines will promote a procoagulant activity. So as you will see, the cytokines will promote more generation of thrombin. So remember, prothrombin is factor 2. Nasa common pathway yun. There's more production of this thrombin and then eventual formation of fibrin. And then there would be too much of this thrombin formation, causing thrombosis in the small and mid-size vessels. However, what about the anticoagulant parameters? The anticoagulant parameters are all impaired. Or TFPI, usually kasi, di ba, there is a mechanism that will may check and balance between them so that the coagulation will not proceed too much. So this anticoagulant mechanism, which normally checks this coagulation, are also impaired because of the presence of the cytokines. So what is impaired? Your antithrombin 3, the protein C, NS function are impaired, and also there is an insufficient tissue factor pathway inhibitor. And lastly, as you will see, there would be suppression of fibrinolysis. And di ba, usually once na after the clot has been formed, after a few days, there should be a normal fibrinolytic mechanism kasi hindi pwedeng masyadong madaming clot sa katawan. But eventually, this fibrinolysis is also eventually suppressed by what you call the plasminogen activator inhibitor 1, your PAI1. So as you will see, this is the pathogenesis of TIC. Until eventually, when there is too much thrombosis all over, it will lead to tissue failure or organ failure. Kaya yung iba, usually, nag-thrombose na sa kidney, nag-renal failure na. There's a need for dialysis. For the diagnosis of DIC, there is no single laboratory test, but what you can see them clinically, they keep on bleeding. Okay? So what would be the test that will help you? Think of, ay nako, meron na akong DIC. So number 1, look at the CBC. Usually the platelets are decreased, primarily because the rationale, the platelets are consumed during the clotting process. You can check for the peripheral blood smear, to double check, is this TTP ba or DIC? But usually, you have to look ayan sa platelet. Should be decreased. Aside from the platelet, since we're talking about secondary coagulation parameters, you anticipate both the prothrombin time and the activated prothrombin time, or APTT, to be prolonged. Why should it be prolonged? Because you have consumed all of your coagulation factors already. So if you have prolonged PT and PTT, then you anticipate bleeding actually na to the patient, especially in this DIC. Now, serum fibrinogen is eventually consumed because of the consumption of all the coagulation parameters. Remember fibrinogen, okay? Nasa last part kasi yung fibrinogen. It is lysed by thrombin to become your fibrin clot. And of course, your FDPs and D-dimer. Now, the D-dimer and FDPs are actually as a result of the breakdown of fibrinogen to form fibrin. So you expect actually an increased D-dimer and an increased fibrin degradation products among patients with DIC. Okay? But not all the time they have. You have to look back at your patient again. Sometimes, some of these D-dimers can be also be positive among those who have an infection. So you look at your patient. Always go back to your patient when you are interpreting this laboratory test. Okay. So how will you help your patient? Again, you look back at the clinical picture and correlate it with the laboratories that you have. But in DIC, number 1 is you look for the underlying cause. Remember, DIC is not a disease. It is a secondary condition. May pinanggagalingan yan. Hindi lang siya magbe-bleed. You have to look, is there an infection? is he bleeding somewhere, ano? Does he have ano ba ito, may fat embolism ba? Ano ba, is this a trauma patient? So you need multi-organ support. Most of these patients are intubated. Most of them are in renal failure, so they would need eventual dialysis. What about the transfusion support? Of course, you are presented with already bleeding patient, thrombocytopenic. You have to transfuse platelets. And for those with prolonged PT and PTT, you can give fresh frozen plasma or cryoprecipitate. But if you are presented with a bleeding DIC patient with a decrease in serum fibrinogen, then it's best to give cryoprecipitate. So you need to keep on transfusing. Hindi lang platelets, not only the FFP. Because of the persistent bleeding, you will have anemia as well. So you need to correct as well the hemoglobin because your patient is already critical. And now, aside from transfusion support, what about heparin? Now, some studies have postulated since you are one of the pathophysiologic mechanism is that there is widespread thrombosis or disseminated thrombosis, is that maybe you can give a low molecular, just low dose heparin. Now, not all studies have supported this because it's very difficult not to assess where are you now, are you already in the clotting phase or are you already in the bleeding phase, because remember heparin it will bind with your thrombin and it is an anticoagulant. Your patient will continue bleeding if you give heparin. Hence actually not it is not readily supported giving heparin for treatment among DIC patients. Now, your recombinant tissue factor pathway inhibitor, they are not readily available in our country. But of course, in order to, this has been proposed because some, remember, going back to the mechanism, your normal anticoagulant processes are all impaired. So in order to counteract the prothrombotic um, condition of DIC, they want to give these types of medicines. But actually, I've never tried given TFPI or even APCC. And antifibrinolytic agents in the form of tranexamic acid, studies have shown that it's best to reserve this or not to give this antifibrinolytic agents because remember, diba, your fibrinolytics are already, or the natural fibrinolysis is already impaired. So, somehow your body will try to attempt to remove the clot coming from the body. And if you stop that fibrinolysis by giving an antifibrinolysis, you may promote more clots in the system. That's why this actually giving antifibrinolytic agents some articles would say not to give, but in an already bleeding massively bleeding patient all over, some would even, of course, kasi nagbe-bleed na, you can give tranexamic acid right away. But usually, for the clinical use, I usually reserve antifibrinolytics in a bleeding DIC. It's best to correct all the parameters, platelets and FFP or cryoprecipitate. And of course, look at the underlying cause. Even if you keep on giving platelets or FFP, but if you do not address the underlying cause, for example, if there's another new onset infection, wala, sayang lang. All the blood products will be put to waste. So that's for DIC. Now we're nearing our second to the last topic, which is TTP. Okay, so TTP-HUS. So TTP is actually an acute life-threatening disorder, and in most of the cases, this is idiopathic. Usually, you see this among female patients, 30 to 40 years old, and if left untreated, the mortality is high. However, when you see or if you're able to identify this disease, ito sakit talaga siya, the survival rate is high. Now, they can have relapses around 10 to 40%, ranging from months to years until they have been reported. So what is TTP? Now in TTP, your thrombotic thrombocytopenic purpura, normally, we all have what we call the Adams TS13, okay? So your Adams TS13 stands for your A disintegrin and metalloproteinase with the thrombospondin type 1 motif member 13. So it's a bit long, but this enzyme is a very important enzyme for cleaving your von Willebrand multimers, okay? So usually kasi taga-cleave siya, okay? Yung Adams TS13. The problem is, in this TTP, your Adams TS13 is deficient, whether inherited, there's an inherited type of TTP, or whether acquired. There are antibodies that inhibit the Adams TS13 enzyme. So what happens if you have a decreased Adams TS13? This results in large multiples of von Willebrand factor. Remember, these are normally, these are, it should be cleaved in the blood. Hindi kasi pwedeng malalaki yan. May taga-cleave talaga sa kanya. The problem is, what is left, because the enzyme is deficient, you're left with very large von Willebrand factor multimers. So what happens if you have this very large multimers? There is what you call spontaneous aggregation of the platelets and activation of coagulation in the small blood vessel. Nagko-coagulate siya. So the platelets are eventually consumed in the aggregation process. Because of the presence of these large multimers, they consume the platelets. And eventually, when this platelet and von Willebrand complex together and they circulate in the body, they will form or they will create shearing of the red blood cells. And when they shear the red blood cells will appear as schistocytes or bite cells. That is what you will see in the peripheral blood smear of a patient with TTP. So, what are the causes again of TTP? It can be primary or idiopathic, meaning wala kang cause, but it is usually acquired autoantibodies. It can be a secondary TTP, may pinanggagalingan na naman. It can be a drug-induced type of TTP. It can be from pregnancy, whether from HELP syndrome, or HELP syndrome stands for hemolysis, elevated liver enzymes and low platelets, and eclampsia, elevated yung blood pressure, nagsiseizure na yung patient mo. Or HIV, SLE can induce a secondary TTP. Malignancy, the last patient that I saw was a breast cancer patient with TTP. So you have to treat the underlying cause, very importantly, and at the same time treat the TTP. Some marrow or organ transplantation as well. So what are the clinical findings in TTP? How do they present? Usually they would present as fever, they would have neurologic changes, whether headache or sensorial changes, and of course, renal impairment. When you do serum creatinine, their creatinine are very high. And aside from the clinical findings, you have laboratory findings of MAHA, or what you call microangiopathic hemolytic anemia and thrombocytopenia. But the primary diagnostic criteria does not need to, you need not have all the pentad, okay, in order to diagnose TTP. All you need to have is these two primary diagnostic criteria. One would be thrombocytopenia and the second would be microangiopathic hemolytic anemia. So how will you know, Doc, ano yung microangiopathic hemolytic anemia? So when you look at the peripheral blood smear, you should see schistocytes, and second, LDH should be increased. That is under microangiopathic hemolytic anemia. The presence of these two already sufficient to establish and of course begin plasma exchange immediately. So this is what you see in microangiopathic hemolytic anemia. You will see your schistocytes. These are fragmented red blood cells. And your LDH or your lactate dehydrogenase is high. And of course, your Coombs test should be negative. In TTP, you anticipate thrombocytopenia, anemia, reticulocytosis, as I've mentioned, schistocytosis. Your NRBC or nucleated red blood cells are there because of the presence of hemolysis. And remember, when you have hemolysis, the red blood cells are broken down because LDH is seen in the RBC cell wall. So when your RBC is broken down, the LDH will be increased. Your indirect bilirubin or your B1 is anticipated to increase. Remember, in when during the RBC breakdown, him, diba, will be released and then will eventually be broken down to biliverdin. Serum haptoglobin it complexes with free hemoglobin. So when it is consumed during the process of hemolysis, the anticipated product is as decreased serum haptoglobin. Your PT and PTT may be sometimes normal in patients with TTP kasi nga it's the platelet yung nauubos sa kanya with complexation with your von Willebrand factor. So of course, if you do plasma pheresis, sometimes aside from the plasma exchange, you can give steroids or other immunomodulatory therapies such as giving rituximab to dampen the antibodies, or vincristine or methylprednisolone steroids pala yun, or vincristine or other chemotherapies. Okay, so this is just an example of a patient undergoing plasmapheresis. So usually when you do plasmapheresis, you should have an access whether through IJ or if the patient already has a fistula, so you can use it. And he is hooked to a special machine where the machine will get the blood and clean its plasma of these antibodies. Now, when you return the plasma, you can give additional FFP to the patient or even cryosupernate in order to replenish some of the plasma that you took from the patient. So in a day, you can have uh, once or twice plasmapheresis. Now, you can have to keep on giving plasmapheresis or doing the plasmapheresis until your platelets are increased. So again, how do you do it? So in plasma exchange, there is removal of your Adams TS13 autoantibodies. And of course, you replace the normal protease activity by giving cryosupernate or fresh frozen plasma. Now, the prognosis overall, they have a very good response when you do plasmapheresis. But some, even if you do plasmapheresis, not all of them will uh, not all of them will respond to plasmapheresis. So there is what you call the refractory type of TTP, and of course that's a bit hard. That's at the early mortality rate of 10 to 20%. Now that's for TTP. There is TTP slash HUS because sometimes they may present the same. The HUS syndrome or your hemolytic uremic syndrome. The hemolytic uremic syndrome is very common in children, and what will present is that usually diarrhea itong patients na ito. And it's renal disease that is the classic hallmark of the acute oliguria. And the diarrhea is usually brought about by E. coli, or your E. coli O157H7. And of course, the treatment is primarily actually dialysis. Okay? Kasi parang pareho yung itsura niya sa peripheral blood smear. Now, so going back, again, when you have problems in your primary hemostasis, think of your platelets. When you have a platelet quality problem, a qualitative platelet dysfunction, think of von Willebrand, your Glanzmann. There's a deficiency in your 2B3A, your Bernard-Soulier. Immune thrombocytopenia may be primary or secondary causes. And again, for those with primary ITPs, we have discussed the different mechanisms thrombopoietin add to giving immunomodulatory medications, danazole to counteract your T cells, B lymphocytes in the form of your anti-CD20 or rituximab, and even plasmapheresis to remove the antibodies. And you can also do splenectomy in order to remove the place or the area where these sensitized platelets are consumed. You also have secondary hemostasis in the form of hemophilia A and hemophilia B. And of course, what can treat this patient or cure? It's just liver transplantation. We've also discussed a condition, not a disease, the condition DIC, disseminated intravascular coagulation, and it's primarily you have to treat the underlying cause and do uh, blood transfusion support, and of course, your TTP, HUS, anticoagulation, So in summary, anticoagulation, and fibrinolysis, we've also discussed some disease entities that are involved if you have a problem with primary coagulation and secondary coagulation. So that will be the end of my slide. Okay, so uh, are there any questions from the group? This Actually, this lecture will be uploaded by, is Gea here? Is Gea here? Where's my residence? Okay. So if you have additional questions, it's okay ha. You are if you are shy, you can ask me. You can email me ano if you have additional, if you want to have, wait, additional questions, okay? Um just the take home message. Of course, you will not be able to memorize the disease entities in hematology. But when you are presented with a bleeding patient, always think, ano ba ito? How's the platelet of this patient? Kasi going back to med school, when you are presented with a bleeding patient, think of your primary and your secondary coagulation parameters. Parati yan. I always ask that to my residents kasi that's very basic for a doctor. Hindi yung bleeding bleed. Refer ka na lang. Paano kung ikaw na lang talaga yung doctor doon? Then you have to think, what is the normal mechanism ba in a bleeding patient? So first, you know that aside from the reflex vasoconstriction, you think of the platelets. What is the primary hemostasis of this patient? Normal ba siya? What about the secondary mechanism, the PT and the PTT? Is it normal? Kaya nga that's very basic, kahit yun nga lang yung dalawa muna ang i-check, If you are thinking of bakit ba bleed ng patient ito. And remember, you cannot always pinpoint that the blood has a problem. Remember, it can be of organic cause. Kunyari, for example, madaming pupunta sa clinic ko. Doc, pina-evaluate ako kasi I have very frequent epistaxis. Pupunta yan sa iyo. So, as a hematologist, you are thinking, ano ba ang problema dito? Is it the blood? Oh, so you check for the CBC and PT-PTT. Normal lahat. So at the back of your mind, even if it's a normal, but bakit normal ang platelet niya at saka yung PT-PTT niya, your primary and secondary coagulation. But the patient still has bleeding. So syempre, I'm thinking na, syempre remember, mucocutaneous, then you think, baka mamaya may von Willebrand factor to. Even if the platelet is normal in number, then remember, baka it's the quality of interaction between the platelets and the collagen site, ang mangyayari diyan pagka hindi you can check for von Willebrand factor deficiency. But guys, always remember, look at the organ of your patient. Look for organic cause, meaning baka hindi naman sa dugo. Look at, baka kasi may sugat siya dito. So, when one of my patients, pagka-check, may polyp pala dito. Yun yung nagbi-bleed. So, kahit na anong check mo dyan, normal ang CBC, normal ang PT-PTT mo. But there is an organic cause, meaning it's anatomic already. So, you always need to think if there is also a possible organic cause in a bleeding patient. Okay, so that's one of my take home. Basta kailangan alam niyo yung platelet, tsaka PT-PTT. Because even if you will go to surgery, to OB-GYN, or to internal medicine, most of course in internal medicine as hematologist, you should know, okay, the primary and secondary coagulation factors. So anyway, I have my question. Hi, Doc, from Claudette. What would be the reason for unresponsiveness of patient to plasmapheresis in cases of TTP? Okay, so remember, when you have, pwede pa rin ba, Doc, ano ba ito? Blood vessel disorder. Wait, dun muna tayo sa TTP for Claudette. Okay, sometimes when you have an unresponsive patient for plasmapheresis, kaya ilang plasmapheresis na I had one case before during my training years. I think parang naka-7 na kami na plasmapheresis. Hindi pa rin siya nagre-respond. Ang platelet niya, less than 10, less than 20. Kita mo yung smear niya, punong-puno ng schistocytes. Primarily kasi this patient has a very big nasopharyngeal CA. Kaya nga, when you are dealing with TTP, make sure you are also dealing with the underlying cause. Kasi yung nagre-release ng autoantibodies might be coming from the mass itself. So even if I give my plasmapheresis and remove all the autoantibodies, but I do not address the cause or the origin of all the autoantibodies. For example, if meron siyang mass, may nasopharyngeal CA, hindi naman makimo-kimo kasi nga ang pangit na ng it's a stage 4 type. So that it would be one of the reason why your patient will be unresponsive to plasmapheresis because you're not also dealing or treating the underlying cause. Okay? So, ano pa ito? Wait. Pwede rin po ba, Doktora, blood vessel disorder? Anong blood vessel disorder? Hindi ko na-gets tong tanong ni Anthony.
No, kasi po yung kanina po, yung nagme-mention po kayo ng case na what if normal yung coagulation studies niya and nagpe-present pa rin yung bleeding yung patient, pwede din po ba i-consider natin yung blood vessel disorder?
Okay. Kasi parang lahat na check na, 'di ba? Sometimes kasi you have to look at the anatomy. I agree, yes. It can also be a blood vessel disorder. Sometimes the blood vessels, lalo na dito di ba baka may naririnig kayo kasi I have a lot of ENT friends, okay, whom I refer to when I have patients with persistent epistaxis. And usually kasi pag sinisilip nila, manipis daw yung the lining, makikita mo raw puro clots na, okay? So, yes, it can be also a blood vessel disorder. If that's, Anton. Any more questions? Kasi alam mo, you will be presented with this. Sometimes I would be referred to with bleeding, yung obstetric, not obstetric, pero profusely bleeding female. So, dugo ng dugo, nireregla, ilang taon na? 46 years old, 47. So, of course, it should be both the gynecologist and the hematologist. Kasi the gynecologist is there to check if there are any organic causes. When you say organic, merong bang myoma tong patient kaya dugo ng dugo? Baka naman merong what you call this, there's an continuously bleed. So, marirefer because I have to assess, baka may ibang problems pa ito that's affecting her bleeding. So, in hematology kasi, you cannot only focus also on the platelet only and the PT-PTT. You have to go back to the whole history of this patient. How is remember if you have other systemic problems, especially mga increased creatinine, okay? The increased creatinine, if you will read, syempre hindi ko na dito na mention, but I mentioned that in uremia. Kahit na normal ang platelet mo, but the fact that there are too much toxins in the body, you have an increased bleeding if you have an increased creatinine. Kaya yung mga dialysis patients, I work at NKTI, I'm one of a visiting consultant there. So I see a lot of bleeding patients. Primarily, it's secondary from their uremia. Okay, so these are the these are the factors that you have to take on consideration to get a very thorough history. What are the medications that the patients are taking? Ano ang family history niya? Kaya nga, di ba, I keep on telling my students, when you are presented with any patient, you will get the diagnosis right away by just doing a proper history and physical exam by 90% of the time. But in hematology, I need to check a portion of the blood, the peripheral blood smear, para some of the possible or most likely hematologic diagnosis will be may ano ka na, meron ka ng, kasi TTP, isang drop ng blood lang yan. Pag makita mo yung schistocytes, oh, this is TTP, this is an emergency, you have to give plasmapheresis right away. Okay? So anyway, if may questions pa ba? 11:45 na pala. Doc, pa-anonym. Sorry, binasa ko na ito. Na menstrual blood po, tapos bata pa po yung... Pwede po ba? Yes, okay. So I have a question here. If you have menorrhagia, more than 80 ml, menstrual blood po, tapos bata po yung patient, pwede pa po ba related sa coagulopathies? Yes, very, very yes. Remember, if you read on von Willebrand's disease, you know this congenital abnormalities, the congenital hematologic disorders, yung Glanzmann thrombasthenia, the Bernard-Soulier, the von Willebrand. Yung von Willebrand ako, very notorious yan. Pag nagregla yung bata, regla ng malakas. So usually, most of these heavily bleeding teenagers are evaluated for possible von Willebrand disorder. Yes. So, very important. So, you have to read that. Kasi kailangan lang, you have to, at least na-mention na during this lecture that, remember, they can bleed, mucocutaneous yun. Von Willebrand, yes, definitely. Pag profuse ang menses, especially among those who are very young patients. Okay? So, any more questions? Okay, so anyway, you can email me if you have additional questions. I think this lecture will be uploaded in your Moodle. So yes, if I hope you learned a lot from this lecture. Okay, again, so we can have the rest of the, you can have your lunch now. Okay, so anyway, sige, goodbye.
Thank you, Doc.
Thank you so much, Doc.
Thank you po, Doc.
Thank you, Doc.
Thank you, Doc.